My name is David Lesher. I'm the Government Affairs Director at PPIC, the Public Policy Institute of California. I'm sure many or most or all of you are familiar with PPIC, but we are a nonpartisan, independent think tank based in San Francisco with offices here in Sacramento in the Senator Building, and we do work on a variety of topics, virtually all the topics that cross a plate here in Sacramento, including obviously safety net issues, which we'll talk about today. A couple of quick announcements before we get going. We've got a lot of ground to cover, so thank you to the James Irvine Foundation. This event is part of a series called the James Irvine Foundation Briefing Series that we've been doing all year on a number of topics. I also wanted to say a special thank you to the California Program on Access to Care, which has helped with the production of the report that you're about to hear from PPIC. One announcement about an upcoming event that we are hosting. It's in San Francisco. If you want to go there, it's on December 11th. It'll look back at the election and at their results, and then kind of what they mean going forward. The participants include Warren Olney, who's a radio commentator in Los Angeles, Mark Shields, who's a nationally syndicated columnist in Washington, and Deborah Saunders from the San Francisco Chronicle. A couple of other quick announcements. This is being taped for broadcast, so if you want to avoid an embarrassing moment, you might silence your cell phone. Also, on your chair, there should be a copy of the report that you're going to hear today, as well as there's a little salmon-colored sheet that is an evaluation form. If you wanted to fill that out at the end of the event and drop it off on the table on your way out and tell us how you think we did, that would be very much appreciated. So quickly, we're going to an overview of the event today. We're going to hear a presentation about the report released recently from PPIC, Access to the Healthcare Safety Net in California. And then following that, we'll have a panel discussion about the issues raised in the report and other issues. So first, we'll get started right away. I'll introduce Shannon McConville to come up and give a presentation on the report. Shannon is a policy associate at PPIC, has done a significant amount of work on healthcare areas, most recently on Medicare profiles. So please welcome Shannon.
Thank you. Thank you all for coming. I wanted to first acknowledge my co-authors on this report, Laura Hill and Helen Lee. Also the California Program on Access to Care for providing funding to support this project. So as Dave mentioned, first I'm going to provide a very brief overview of some of the findings from our report, Access to the Healthcare Safety Net, and then we'll move on to our panel to discuss some issues in more depth. So the healthcare safety net is a crucial component of the state's healthcare delivery system, providing access to medical care for everyone, regardless of their insurance status or ability to pay. Core safety net providers include public or county-run hospital systems, health centers and community clinics, and hospital emergency departments. These providers care for a substantial portion of the state's uninsured and Medi-Cal populations. Many of these providers are also tasked with and focus on providing culturally competent care, and so they also serve sizable numbers of immigrants as well as many patients with limited English proficiency. Medi-Cal, California's Medicaid program, is the primary funder for the state's healthcare safety net, providing funds both through patient revenues as well as additional funding mechanisms. So the healthcare safety net is poised to play a critical role in the state's implementation of federal healthcare reform, the Affordable Care Act. Expanding capacity and ensuring access for the millions of low-income Californians expected to gain coverage as the result of reform will be essential. At the same time, safety net providers will remain the primary source of care for those that continue to be uninsured. And with available estimates indicating that between 3 and 4 million Californians will likely remain without coverage post-reform, balancing these roles could prove challenging, especially in areas that currently may have less safety net resources and may continue to have large numbers of uninsured residents. To really inform planning decisions, we need to know where those 3 to 4 million remaining uninsured will be located throughout the state at a very local level. And unfortunately, this information is harder to come by, especially at sub-county areas. So to help inform these efforts, we looked at the current status of safety net access across California's zip codes for key safety net user groups. So to start, we looked at access to the safety net two different ways. First, we calculated a simple proximity measure. This is simply the physical distance to a safety net to the nearest provider for all zip codes in the state, to examine just a broad measure of potential access. And while this is simple to construct and interpret, physical distance does not tell us anything about the capacity of these nearby safety net providers, nor how crowded they may be due to high demand for their services. To address this, we also created an accessibility measure for all zip codes that takes into account both the provider capacity at nearby facilities as well as the size of the local population that may need to use those services. This is calculated for each clinic as the ratio of primary care providers to the number of low-income people within a certain distance. I should note that we are only able to include clinics licensed through the state in this analysis in order to have those capacity numbers, and so the clinic accessibility measure does not include all clinics throughout the state. Most notably left out are county-run public clinics. We also did this for emergency departments, and those results are in our report, but today I'm going to focus on access to clinics. Ideally, we would like to examine these access measures for the remaining uninsured population specifically, but again, this is difficult to do. So instead, we focus on key groups that rely heavily on the healthcare safety net for care, including low-income individuals, those under 200% of the federal poverty level, Medi-Cal beneficiaries, and unauthorized immigrants. Unauthorized immigrants are projected to be one of the largest groups remaining uninsured because they are excluded from ACA's coverage expansions. And based on previous work by my colleagues, we have local level population estimates for the unauthorized to serve as an indicator of where there may continue to be sizable uninsured populations post-reform. So we start first with the simple proximity measure and look at distance to the nearest clinic. The good news is that safety net providers, clinics in particular, are located near the primary populations they serve, including groups who will likely remain outside the scope of coverage post-reform. So although there are differences across regions, even among more urban areas in the state. So throughout California, about 70% of people we designate as safety net user groups are located within 2 miles of the nearest health clinic. In Los Angeles County, these numbers are even higher, but in places including Sacramento and San Bernardino, far fewer safety net users live nearby a health clinic. But again, this only provides a sense of the simple physical distance to a nearby provider without any knowledge of that provider's ability to serve the medical needs of nearby populations. So now we turn to some regional maps that show the accessibility measure for clinics, and to get a sense of where there may be remaining uninsured at a sub-county level, we overlay these accessibility measures with information on the size of the unauthorized immigrant community in these areas. So this map is of the Southern California region. Again, it shows clinic accessibility, which is shaded in green. And this can be thought of as the average access of people within a given zip code that incorporates both capacity available at nearby facilities, as well as the possible demand for services from surrounding nearby areas. Darker shaded areas have relatively low clinic accessibility compared to other areas throughout the state. And to provide a sense of where remaining uninsured populations may reside, we use crosshatches to indicate areas that have relatively large unauthorized immigrant populations. So in this map, areas that are shaded dark green and have the crosshatching indicate places that currently seem to have less clinic resources available, but that could continue to have sizable uninsured populations even after ACA's coverage expansions. We see this in parts of Los Angeles County, in communities in the San Gabriel Valley and near the port, as well as most of the populated areas in San Bernardino and Riverside counties. And this is showing the same thing for a different region, the Central Valley and Central Coast. Again, the darker areas indicate low clinic accessibility, and crosshatching signifies large unauthorized populations. While several communities appear to have relatively low clinic accessibility, most places with a sizable number of unauthorized immigrants fall into the middle range on clinic accessibility. Although in places like Monterey County near Salinas and in central Fresno, communities with many immigrants are adjacent to low clinic areas, which could make access difficult. You can also see Sacramento at the top of this map, which appears to have relatively low clinic accessibility across large parts of the county. Our report and website have more detailed maps and tables if you would like more information on a particular region that wasn't included in this. So while our spatial analysis of access suggests that California's current safety net system is well distributed throughout the state, these maps and measures don't tell us anything about how actual safety net providers and communities are preparing for the changes brought about by the ACA. To provide some sense of this, we also conducted case studies in two areas, Los Angeles and Monterey, in order to gain insights from people on the ground who are actively planning for the challenges and opportunities brought about by ACA implementation and what it will mean for safety net providers and the communities they serve. Which brings us to our panel. Rather than describing what other people told us about how they are planning, we wanted to bring together and let you hear from the people that are organizing and actually doing it. With that, I would like to introduce the moderator for our discussion, Dr. Nadereh Pourat, who is the Director of Research for the UCLA Center for Health Policy Studies and has studied access to care and patient outcomes within the safety net system in California. Our two panelists will be providing perspectives on the issues facing safety net providers, specifically California's health clinics and immigrant communities. Carmela Castellano-Garcia is the president and CEO of the California Primary Care Association, which represents community clinics and health centers throughout California. And Ronald Coleman is the government affairs manager at the California Immigrant Policy Center, which advocates on behalf of the state's immigrants and their families. And so with that, I'll invite the panelists up and we'll start our discussion. Thank you so much.
Good afternoon. Nadereh Pourat from UCLA Center for Health Policy Research, and I'd like to thank PPIC for giving me the opportunity to moderate here today, and also thank you, Shannon, for a great presentation on the report, which provides a lot of insightful information on the safety net in general, on the challenges that the safety net is facing, and also of the populations that are the safety net has served and are to serve with the coming changes in California. So I wanted to just sort of discuss some general issues in terms of the opportunities that are facing the safety net system, as well as some of the challenges that are facing the system, and also provide a little bit of data about the populations, a little bit different from what we just heard. So in terms of the opportunities, you know, the demand for primary care has been increasing, and that's due to lots of different things that are going on, different trends in recognition of the role of primary care in delivery of access to care, and the role of primary care in perhaps leading to efficiencies in delivery of care, may be the answer to some of the major problems that the healthcare system is facing. The demand is also for the demand for care has also increased for the safety net system due to the recent economic downturn, where a lot of people, by having lost their jobs and their insurance, are now facing, they have to search low-cost care in different places that they may have been going in the past. So there's a surge in the number of people seeking care within the safety net. In terms of opportunities, we're also looking forward to full implementation of healthcare reform and the number of people that will gain coverage under the Act. And that also is presenting an opportunity for the safety net system, which we hopefully will hear a lot more from the panel. Healthcare reform also brings an infusion of funds into the healthcare safety net delivery system to develop more capacity for care. So to provides resources so that you could do some more capacity building. And another little part of the Act is to provide an opportunity for residents to serve in community clinics or comprehensive health centers, which means in terms of workforce, potential workforce for the system. In terms of challenges, we're looking, you know, the safety net has always faced resource constraints. And those constraints are not necessarily going away despite the potential opportunities that ACA provides. And if the number of people that are going to seek care at these organizations increases or diminishes, those resource constraints will be different and challenging. The pressures to achieve more efficiencies in care probably are felt even more within the safety net, the resource constraints, and also the trends in developing more to deliver more primary care also pose a lot of questions for the safety net in terms of reorganizing and thinking through how care is delivered, how are they going to change things in order to deliver care still to all the people who are seeking care at these organizations, but do it in a way that actually is more effective and achieves the goals better. And then the really big question, I guess, on everybody's mind is how successful will the safety net system, particularly the safety net clinics, will be, as well as the hospitals, but how successful will they be in retaining the patients that will gain insurance under ACA? So whether they are going to be able to retain those people, what strategies are going to be employed to retain those individuals, and of course, serving the needs of the remaining uninsured. And we know that the composition of the remaining uninsured is going to change. So proportionally, the percentage of the population that is going to remain uninsured is going to be more unauthorized immigrants, just because they are not eligible for participation in the forms of coverage that are going to be available under ACA. So I wanted to just provide a little bit of information about some of these populations that we're talking about as a background and context for the discussion that we are about to have. So one of the opportunities that has happened in California has been the low-income health program under the second Medicaid 1115 waiver that the state got approved from CMS, and that is a program that provides health coverage for the low-income uninsured individuals that are not eligible for existing programs, existing public programs. And the low-income health program to date, actually as of June of this year, has already enrolled about 553,000 individuals. The program is part of the Bridge to Reform, so the goal was to get people covered. It is not an insurance mechanism. It's not portable. It's bound to the county geographic area, but it provides an opportunity to provide coverage to these individuals, enroll them in the programs, deliver services to them if there is pent-up demand, if there is unmet need, to address some of those needs. So when these people transition, hopefully they are health-wise in a better situation than they started with. The population is about 50% are ages 50 to 65, and the 48% are female. So you can see more males incorporated in this population because those are a larger proportion of the low-income uninsured populations. About 40% are between 0 and 25% of the federal poverty level, so very, very low-income populations. 35% Latino, and about 20% are Spanish-speaking, and less than 10% of them had ER visits, and less than 3% were hospitalized. These are pretty low numbers compared to state averages. And this is for the first 3 quarters of the first year of the program. So it probably will increase a little bit more once you look at the full year, but it's still lower than other populations. And then we also have the unauthorized population in California. The latest estimates is that about 1.07 million of them, this is adults and children, would have been eligible for the reform, and they are not because of their unauthorized status. Of the adult population, about 50% don't have insurance coverage. And we have done some recent analysis of this population. Lower rates of diabetes, asthma, high blood pressure. We could discuss why that is. You know, there are reasons for those lower rates. Similar rates of psychiatric distress. This is feelings of depression or anxiety. And also a little bit higher rate of obesity and overweight than the US-born. I'm sorry, I was comparing the population to the US-born. And similar rates of smoking and binge drinking, but lower rates of ER visits and multiple doctor visits. So a population that is not necessarily unhealthy, their rates, their health status is comparable to the US-born population, and they have much lower rates of utilization. Part of it has to do with access issues, obviously. And then also we have some information on the overall population that's going to be, that's going to remain uninsured. And a lot of those people, about 39%, will remain uninsured because they lack affordable coverage. So they don't have access to affordable coverage. And those individuals are also 66% Latino, 47% limited English proficient, 25% live in California, and they're 15% report fear or poor health. And there's a lot of numbers to absorb, but just sort of provides a little bit of background on who are the people that are likely to seek care in the safety net and don't have insurance. And I did not provide any numbers in terms of who are the populations that will be insured and have insurance and will have insurance and are still potential users of services in the community clinics. With that, I'd like to sort of start the discussion. So we're going to start with a brief discussion with the panel members. And I wanted to start asking the question from Carmela first to talk a little bit about the key challenges that are facing the safety net system in California as you are preparing for implementation of ACA.
Okay, good afternoon, everybody. Well, certainly it bears mentioning that one of the most significant challenges we face today is the tremendous uncertainty around what is the future of the implementation of the ACA. With so much hanging on the election next week, that it is just certainly a time of just tremendous uncertainty and angst around that. But certainly after next week, we'll have some idea going forward. And it is certainly our hope that the ACA will move forward. And, you know, we also have uncertainties in terms of California, not just the presidential election, but certainly what's going to even happen with our own budget crisis. But that being said, and we, you know, being a glass half full thinker myself, you know, we've already overcome so many obstacles getting this legislation passed in the first place, the Supreme Court, you know, I think I'm feeling like we could be unstoppable here. So hopefully the ACA ultimately will go forward. And then certainly there will be challenges even in a successful environment where all the promises of the ACA are there. The $11 billion investment in community health centers that's already resulted in over $200 million to California alone for capital expansions. 45 new federally qualified health centers have already been designated in the state of California as a result of these dollars. So there's already been a significant investment that's allowed us to gear up to focus on our capacity. However, we do anticipate being challenged in the capacity arena. There are many health centers that are already at the maximum levels in terms of capacity that they can handle. And while they're looking at ways to expand or, again, you know, internal efficiencies and all the ways that we're striving to be able to enhance our capacity, certainly that is a challenge. And when you look at what happened in Massachusetts after healthcare reform, where the big question was what will happen to community health centers, well, what happened is there was a 30% increase in the number of patients. Demand was tremendous on community health centers, and they struggled to keep up with that demand in that environment. So we do anticipate that that could happen. And that's going to be exacerbated by the workforce crisis that we face in the state of California, particularly in the primary care arena, with 30% of California physicians being over 60 years old, and that compares to an average of 25% in the U.S. Most physicians are nearing retirement in our state more than any other state in the country. And we also have significant disparities already existing in the demographics of California's providers, where Latinos represent 37% of the population and half of the patients in the clinics, and yet only 5% of the physicians are Latinos. So we have those disparities, and you see that throughout the other workforce types in the state, because certainly community health centers look at the range of providers at our disposal to utilize within the health centers, and so that gives more options, but yet even in that regard, we do have challenges, particularly with the ethnic, cultural, linguistic diversity of our workforce. So I think those are going to be some serious challenges, and that leads to the focus on the residually uninsured, which you mentioned, because certainly it is our hope and expectation, and if Massachusetts is any example, we expect to see that the newly insured will come to the health centers for their services. I think we're, as this study demonstrates, we're well located in the communities where the low-income populations reside, and those are going to be eligible for the Medi-Cal program, for example. 1.6 plus million people eligible for Medicaid. Some of those will be our existing patients. Some are going to be those that are in the vicinities of the health centers. They're going to be looking for a provider. We're going to think that we're very well positioned. But in addition, there will be those who remain uninsured, as has been mentioned. And our challenge will be, because it is our mission, and that is not going to change, to serve everybody in the community despite their ability to pay, their status, their ethnicity. And so the hope would be that as more of our populations are insured and actually have a payer stream behind them, that should result in some stability for the safety net. And in fact, could that balance out and help enhance our ability to continue to see the uninsured? That would certainly be our hope. And those are just some of the challenges.
Thank you. I'm sure more of them will come up in the course of the discussion. So I'd like to turn to Ron for a similar question. What are the key issues facing the immigrant communities as they prepare for implementation of ACA?
Well, generally, one of the biggest issues that we have seen is the lack of comprehensive immigration reform. Obviously, we wouldn't even be having a discussion about what to do with people that have been left out of the Affordable Care Act if we had a comprehensive immigration reform that would move forward. Obviously, there's people that have been here for decades, people that have been in the shadows for decades, and that are doing hard work in California and really making our economy exactly what we want it to be, and improving our economy even through this horrible recession. And I really think, given the lack of political will and some of the divisiveness we've seen in Washington, it's not likely that we'll get to a place to where we can have robust, comprehensive reform moving forward. As we know, this is one of the president's priorities, as he's mentioned on the campaign trail, so it's obviously something that we do hope can move forward, but we need to be able to work with all sides for that to happen. Now, with that said, obviously, it's not just a focus on undocumented immigrants. Obviously, there are mixed status families in California, and mixed status families are essentially families where there is mixed immigration status, where you may have undocumented members of the family and also individuals that are U.S. citizens or lawfully present individuals. So there's many challenges that we see that will face this group specifically because of the family makeup. So I'll lay out a couple broad issues of where I see some of these challenges. First, I think with outreach and education, we're really going to need a robust system, and I'll talk more about that in a second. Secondly, we're going to need to have a robust eligibility and enrollment system to make sure that we're reaching everybody that is eligible for coverage as well. Third, accessing options outside of the Affordable Care Act and preserving the safety net will be the utmost importance, because obviously we know it's not just undocumented immigrants that will remain outside the ACA. It's 3.1 to 4 million individuals here in California that will need a safety net system, and that is not just those who have been left out. The last, there's many barriers that immigrant communities just disproportionately face due to their immigration status. So digging into this a little deeper, Making sure that there's effective outreach and education to immigrant communities. Generally, immigrant communities want to know a lot more about the ACA. You know, there's a lot of confusion out there right now. Families are very curious about new coverage opportunities. California has hundreds of thousands of mixed status families. They're going to want to know who's eligible, who's not eligible. What does the individual mandate mean for them? Public coverage or private coverage, what's available for my family? What will the benefits be? How do they even navigate the complex U.S. health system that we have here? Will coverage be affordable? Obviously, we know there's a high percentage of LEP individuals, limited English proficient individuals in California. It's the most linguistically diverse state in the country. So obviously, people are going to need very good information that addresses their language access needs. We also want to make sure that we have effective and reliable outreach. There's a huge potential for deceptive marketing in immigrant communities because of all the confusion. We don't want to see people going around saying, you know what, under the individual mandate, if you don't have coverage, you're going to go to jail. You know, and then try to sell them junk insurance, limited benefit plans, or mini med plans. You know, people are working hard, and we want them to get enrolled into the programs that are available to them, whether it's the exchange, public programs, or other options in the future. So the second point was getting all eligible family members enrolled. There's going to be a huge challenge with mixed status families with the exchange. Obviously, there's going to be a need for very targeted outreach, not just to Latinos in general or African American communities, but targeted specifically for mixed status families. Obviously, people have concerns and fears about certain information that may be asked on applications, or certain questions that could be asked about Social Security numbers, place of origin, country of birth. These are things that could effectively deter people from putting forth the information to enroll their eligible family members. And that's something that we certainly wouldn't want to see. And that's one of the reasons why a robust outreach and education plan is also going to be useful. We also want to make sure that we have best practices available so that people can access the healthcare needs that are available to them. We want to make sure that we're utilizing community-based organizations, promotors, community health workers, school clinics, and county offices, places where immigrants go and are familiar with accessing services for eligible family members to ensure that as many people as possible can get the care that is afforded to them under the ACA. The third point, accessing healthcare options outside the ACA and preserving the safety net. As I said, it's not just going to be undocumented immigrants that are going to remain uncovered. There's going to be people that are out because of affordability, people that choose to opt out and take a tax penalty, other people that just choose to not participate in public programs. So we really want to make sure that we can get as many people as possible in, because about half of the people that are going to remain uninsured are 200% or less than 200% of the federal poverty level. So it's going to be very necessary for the state of California to ensure that these individuals have a place to go so that we don't overburden other places that are in place to provide care for individuals. So under accessing care outside the ACA, we have clinics. We want to make sure that there's going to be enough funding. We want to make sure that there's going to be enough clinics. We also want to make sure that all the accessibility factors are there. Is there enough transportation for people to get there? Obviously, you know, we know that immigrants live in very rural communities. We've heard stories of people traveling up to 75, 100 miles or more to access clinic care. And that's not something that we think is very sustainable for these particular families. Also, public hospitals. Public hospitals are essentially given DSH funding, disproportionate share hospital funding payments that are made to care for the uninsured and people that don't have any place else to go. We want to make sure that disproportionate share hospital funding is maintained. Right now in the ACA, the funding is going to be reduced by $20 billion up until 2020. So we are very concerned about what that may mean for immigrants who need to utilize public hospitals. Secondly, in this area, EMTALA, that's the Emergency Medical Treatment and Active Labor Act. We want to defend this. We don't want any attacks on EMTALA moving forward. The law has been in place since 1986. It requires all patients that need to be treated, that are in need of care, to be treated, and we want to make sure that that continues to be in place, regardless of what the political spectrum looks like after Election Day. State programs. We also want to preserve funding of state programs since many individuals, not just immigrants, I keep saying this, will remain uninsured. This is emergency Medi-Cal, other state programs like Family Pact for family planning services, other family planning services through AIM. We also want to make sure that we can continue programs like minor consent, where minors can get substance abuse treatment and medical or mental health treatment as well. Also long-term care kidney dialysis, breast and cervical treatment program. Yes, it's time limited, but it is a way for immigrants to access regardless of status. We have programs like Every Woman Counts and CHDP, which provides care for children, in some cases undocumented children. These are things that we really want to maintain moving forward. We definitely know that there's going to be other people that need to be in these programs, so it's definitely going to be incumbent upon the state of California to keep these programs funded as we move forward. The last issue I'll mention as a key issue and challenge for immigrants is the other issues that affect immigrants as barriers. Obviously, immigrants, the type of employment that they have could affect them being able to access. It's not your typical 9 to 5. Sometimes it's 12 to 15 hours a day. You know, obviously, the governor, we did just see the veto of the domestic workers bill. That would have given workers time off, paid time off, to be able to access medical care. So that's something we'd like to see moving forward. There's also material and tangible barriers. Do people have current IDs with a photo? Can they show proof of income? How are they paid? Are they paid under the table? Do they have proof of residency? There could be multiple people cohabitating together in a particular household to where they may not be able to show proof of residency. These are all things that we need to consider as we expand and look at new opportunities and access under the ACA, because it's issues that we're going to have to deal with here in California in a disproportionate way more than any other state in the country. Also, economic barriers, no money for transportation, fear of huge bills. They already have bills and think that they may not be able to be seen. Also, there's a lot of limited English proficiency that we see. Sometimes there even has to be double translation, to where you have to translate indigenous languages into another language and then translate it into English. For example, it may be Karini, which translates into Burmese and then to English. That takes up time, causes more confusion, and is very difficult for the patient and the providers to do their job. So we need to make sure that there's things in place to be able to serve populations that meet these needs. Also, there could be unfamiliarities with paperwork, registration documents, etc. Could be self-advocacy barriers. People may not know what questions to ask. They may not feel right demanding services if it's free or low-cost care. They also may not feel that the provider is adequately servicing them, and may not feel that they have the right to push for what they want. The last thing I'll mention is enforcement programs. You know, obviously we have enforcement programs like Secure Communities, which are, essentially a dragnet for low-level criminals, innocent people, domestic violence victims who are being picked up and essentially being detained and deported. We also have 287G agreements with various counties around the state, to where local law enforcement work directly with federal enforcement agencies to do immigration enforcement. This affects access to care. People are intimidated, they're fearful, and they don't want to be separated from their families. So these are things and challenges that we really need to think of as a state moving forward to be able to make sure that immigrant families feel comfortable under this new realm.
Thank you, Ron, for a thorough, perhaps, I'm sure there's more you can say about all of those topics, but that was a great introduction of all the challenges facing the immigrant communities and also non-immigrant communities, many of whom, especially when you get to navigation issues, navigating the healthcare system, the uninsured people who have been long-term uninsured could face very similar challenges. You don't know where to start and how to navigate the system. We will turn back to Carmela and perhaps you could go over some of the strategies then that you, the organization, and the safety net clinics are thinking about in terms of how to deal with the challenges that you posed.
Well, certainly having to look at our internal capacity and how we can enhance that has really been given a push forward through healthcare reform. One of the opportunities is the embracing of the patient-centered health home, which we are seeing in healthcare reform. And the patient-centered health home has key attributes which we believe are already a central piece of what the community health centers do, but really we're kind of all fall along the spectrum, and so making sure we do it at a level where we can actually be recognized by NCQA, the qualifying body for recognition, is really our goal. And so the patient-centered health home model focused on patient-centered approach to a primary care medical home that provides a relationship and orientation to the needs of the patient and their family. So it's really patient-centric. A hallmark of the health home is that care needs to be comprehensive so that the majority of their physical, mental health needs are taken care of, but even beyond with prevention, wellness, acute care, chronic care. So it's really taking a comprehensive approach, which we are well positioned to do because of the comprehensive care provided at community health centers, where not only do you have medical, but you have access to dental, eye care, even specialty care on site. So we're really, comprehensiveness is a hallmark of community health centers. Coordinated care is another component of the health home, where it needs to coordinate across all elements of the broader healthcare system. This is where we are sometimes more challenged with our fragmented system. But, specialty care, hospitals, home health, community services and supports. But we're, because of the incentives in healthcare reform, we're all being motivated to do more coordination. So that is important for promoting the health home. And then certainly having better access to care, accessible services with shorter wait times for urgent needs, enhanced in-person hours, around-the-clock or telephonic care, and access, these alternative methods of communicating like email and telephone care. So the access issue, in community health centers, there have been issues in terms of wait times and challenges we have having flexibility with our reimbursement system to implement some of these innovations. But in order to be health homes and in order to provide better care, we recognize we are having to move in this direction and embrace these modalities, and that is happening. And then finally, a system-based approach to quality and safety. Community health centers have been, under the guidance of the Bureau of Primary Health Care, really tracking clinical measures for years and focusing on this issue. It's really been an ongoing activity. And so using evidence-based medicine and clinical decision support tools is something that the Bureau has been promoting for years. Well, that is an important component of the patient-centered health home. And so this is really a statewide initiative on behalf of the association to work with our community health centers, and we are now in a partnership with NCQA, the National Committee on Quality Assurance, which is the recognition body, and we have developed a technical assistance program with a goal to have all the community clinics and health centers in the state recognized under NCQA as health homes. So I think this is just an important opportunity we have to really advance our ability to provide better care and remain competitive in the environment, and it will it's certainly a positive piece for our patients. But the health centers are already so well positioned. When I neglected to mention team-based care is another hallmark of the health home, where it's not just physician-centric, but it focuses on all the different levels of providers that can provide care, take care of the entire patient's needs. And we have always relied on the different kinds of ancillary providers to help enhance our team, just because of challenges that we have. We've had to have this innovation for years. Another area where I think we're seeing great advancement in the community health centers is in the area of health information technology. And the Stimulus Act provided incentives for community health centers and public hospitals and small physician practices serving the Medi-Cal population to adopt the electronic health record. And nationally, community health centers have the second highest rate of use, with 74% having made the switch from paper to electronic records. And in California, a survey that we conducted of our membership found that 70% of the respondents had either already implemented electronic health record or were in the process of doing so. So we really have seen this be an important initiative for health centers. We were key in creating CalHIPSO, which is the Regional Extension Center in California, which is drawing down $31 million in federal funding to provide technical assistance on the ground to these designated groups. And we're just really proud of how the health centers have really taken this up, because certainly building a robust health IT infrastructure is going to enhance access to and delivery of comprehensive medical care, and certainly we think will ultimately lead to better outcomes. I do need to say it does put pressures and challenges on the health centers. Implementing the electronic health record is a daunting experience for our health centers, not only in cost, but some of the disruption that they experience internally. But that has really not stopped the wave that health centers are on in terms of moving in this direction. We think that's a very positive thing. And a final piece I'll mention is certainly in this environment, there's going to need to be efforts put into retaining and growing our patient base. Although I said we anticipate the health centers to be popular providers, it doesn't mean that we don't need to invest not only in enhancing our infrastructure, but getting the word out about the community health centers, because they will have options and choices under healthcare reform. And so what we are doing at a statewide level is we've spent the last year and a half doing a whole level of focus groups and research to determine what could be a statewide branding campaign that we could launch on behalf of community health centers. And it has certainly been challenging because there's tremendous diversity among our health center constituency, but there are some very significant commonalities which have to do with the quality care we provide, the comprehensive levels of services we provide, the team-based approach to care. And all this has resulted in our development of an innovative new brand, which is called California Health Plus. And the Health Plus really signifies that the plus that you get when you get care in a community health center, because it just goes beyond the physician patient and really extends to the team approach and the broader approach to your health care, going even beyond primary care and encompassing prevention, culturally sensitive, community-driven, patient-centered environment. So California Health Plus, where we've anticipated it maybe potentially up to 2.2 million newly eligible patients that we could target to select the community health center. And again, that goes to the capacity demands that we'll put on, but some of them are our own patients too, that we need to enroll and make sure that they are educated and have access to insurance. So we really look forward to collaborating with the state and the exchange on those outreach and education efforts, which are absolutely going to be critical to make sure, as Ron said, there's a lot of confusion out there, and those same mixed status families, that's who we're seeing. And there is a lot of confusion. There's going to continue to be, and we need to play a strong role in that education process.
Great, thank you. So I just thought I'll follow up with a question on what some of the challenges and difficulties of acquiring PCMH or medical home certification from NCQA, and I don't know whether you know offhand how many community centers already have acquired the certification status.
Well, in California, actually, in terms of the highest level, level 3 recognition, there were only 2 who have obtained that, but there are many who are in the process, and it certainly is a challenge. There's significant resource investment that's required in order to undertake the whole process and all the changes that have to be done internally. I've been impressed by how many health centers are taking this on their own. Others have to incur the expense of consultants to help guide this process, and that puts a strain on the financially strapped health centers. So it's a combination of bringing outside consultants and some of them utilizing their own leadership internally to try to make this happen. But while they're facing challenges, we're seeing a very strong commitment from our membership to want to go all the way. And we've been providing trainings in conjunction with NCQA. They've all been oversubscribed, waitlisted. People are just hungry to get this information and try to make it happen.
Great. Great. And one more question for you. What about, are you thinking about potential partnerships, whether it is in the to-be-formed accountable care organizations or some other formal relationships with other providers, including hospitals or, more with specialists, so that you could actually not only deliver the primary care, but be able to send patients to other providers, but retain them and bring them back to the community clinics?
This is going to be an absolutely essential component of us being successful in health delivery system transformation, which is a key piece of what we expect from healthcare reform. But a lot of that is driven by local processes and local politics and local relationships. So certainly as a statewide association, we have looked to how we can leverage our statewide relationships with health plans or entities such as the Health Benefits Exchange and what we can do to help support that. But ultimately, it is up to the local health centers and their local clinic associations and leaderships to devise strategies to enhance their partnerships. But that's absolutely essential. And as I alluded to earlier, I think the good thing is the incentives are on both sides. I mean, it isn't that historically the clinics haven't wanted to collaborate, but they've faced barriers in certain parts of the state and from certain segments around that collaboration. And so now I think there's more incentives. The hospitals are certainly incentivized to how they're going to work with primary care to keep those readmissions from not happening. There's opportunities through ACOs to look at the role with primary care. And so we are definitely hearing more and more about the potential for collaboration. And also, I think it's important, too, that the role at the local level of bringing all the providers together to look at these issues. It's about local government, the public system as well as the private system, the IPAs, the physicians coming together with the community health centers, and we are seeing some of that happen, and we'd like to see more.
Great. Thank you. And Ron, I was wondering whether you could talk a little bit more about some of the efforts that you're taking on in terms of helping people enroll, helping them with eligibility determination, some of those big challenges in getting people into the forms of coverage that are available.
Yeah, so one of the things we're really hoping that people are informed about what information is out there and what's available. So we've made a few materials that we've published to make available for immigrant rights advocates and service providers. We have another one that's going to be coming out in 2 weeks, and we also have community education materials available as well. But we're also working with the state, of course, with the exchange and doing advocacy there, and also working on a lot of the bills that are related to health reform implementation to ensure that we have things in place that can help immigrant families. We were very pleased with Western Center's bill, AB 1296, which streamlines enrollment because it really does make it easy for immigrant families to, have no wrong entry into finding health coverage available for eligible family members. We also will be working on the new iteration of SB 970, which was the horizontal integration bill, which really is a good way to connect immigrants to public benefits other than health care, such as CalFresh and CalWorks, if they're eligible for those programs. Another thing we're working on right now with the feds, as I mentioned before, CIR is ultimately what we need, comprehensive immigration reform. That's essentially the silver bullet, but it depending on what the policy looks like, of course. But I will say, the Obama administration did do administrative relief for Dreamers. Essentially, this was a pool of individuals that are 16 years old to 30 that have arrived in the United States before June 15th of 2007. And unfortunately, after he granted or allowed individuals to begin applying for deferred action status, he essentially restricted them from being able to get coverage in the exchange, in Medicaid, and also in the pre-existing condition insurance plan. So, this is a big problem for us as well because it essentially creates a two-tiered system. The ACA says that if you're lawfully present, you can get opportunities for coverage. However, these folks will essentially be lawfully present. So we are really concerned about this because it essentially has huge impacts here in California, where we have a huge number of individuals, a little under 400,000, that are going to be able to receive deferred action. Luckily, we have programs in California through PRU-Call eligibility, permanently residing under color of law, which essentially means the Department of Homeland Security knows you're here, but does not have the intent to remove or deport. So we do think that people that find themselves in this situation will be able to get into public programs that way. But ultimately, it's a mistake to not include these individuals into the exchange. They're young, healthy individuals that would bring more people into the purchasing pool and bring down costs for all of us. So outside of those things, we also want to make sure that we can keep the programs that we have available today. those programs that are available for lawfully present immigrants, those programs that may be available regardless of status. We also want to make sure that there aren't any additional cuts to any programs. You know, one of the things the California Immigrant Policy Center focuses on is the state budget, and we are very concerned about really maintaining the programs that are currently in place now. All eyes are on the initiative to see what happens there, but you know, health and human services programs have been cut over $15 billion since 2008, and you know, with cuts at the federal level, state level, and also local levels, it really does hurt access to care for immigrant families that are trying to find it.
I just wanted to add, I mean, and it echoes the comments that Ron had made, but in our case studies down in Los Angeles, one of the strategies that they're using, and he had mentioned it, the Promotora model, and that there was really a lot of activity going on there and a lot of excitement and replication even beyond the Latino community where it had been originated. And so the Promotora is a peer-to-peer education, oftentimes women within the communities providing information both about what is accessible, what programs are accessible, helping with enrollment and things like that, but also where they can access care. And they seem to feel like it was being successful in a lot of the communities that we went to, and actually was being expanded into other communities. We spoke with someone from the Korean community, and they were doing a Promotora model there as well. And so just, you know, one of those kind of on-the-ground local things of trying to connect people to what is available. And so,
and we really do see that as a useful model, and we're really interested in looking at ways that we can find funding mechanisms for community health workers and promotoras, because these are the folks that immigrant community members trust. You know, they really do work with families to tell them what types of care that they can access, and it's much more than health care. You know, it's about accessing public benefits that they are eligible for, and really making sure that they know about these things. And they obviously are people that can speak the language of whatever the language may be, and they're extremely trusted. And we really want to see ways that funding can be provided to these groups of people that do this type of work, because it really is the best way to get the information out there through outreach and education, and to get people enrolled in the programs that they're eligible for.
Carmela, would you like to speak to what the level of use of these kinds of individuals within the community clinics and use of promotoras or similar community health workers, sometimes they're also called, who can, you know, serve several functions. They could serve patient education functions, peer education functions. They could serve as a way of teaching people about eligibility, teaching people about the appropriate use of services.
Yeah, well, certainly community health centers do utilize the promotoras and community health workers. I think some of the challenges that we face is that these are not reimbursable providers. And so these programs are largely grant driven, which means they only last as long as there's grant funding, or some centers somehow manage to build it into their infrastructure, but it's very challenging. And so our hope would be, and there were some provisions in healthcare reform where it looked like could be hopeful that maybe there would be a model for reimbursement, but in terms of what's happening with our state budget crisis and all that, I think we're going to be really challenged to be able to ultimately do that. But it's definitely a value and benefit to be able to utilize folks from the community, because that's where often the promotoras and the community health workers are individuals that are from the community, reside in the community, and are certainly very effective. So I don't see those models going away. I would hope they would grow and flourish, but we really need to look at the funding behind them so that we can make them sustainable.
Absolutely. So actually, Carmela, I was hoping that you could also talk about one of the big challenges that I guess on everybody's mind about this potential conflict between having to not only retain the current population that you're serving who are going to be insured, but also being able to address your mission of serving the remaining uninsured. You know, so we're going to have the demand, you know, you're anticipating an increase in demand, and if the increase in demand comes from the remaining uninsured, so there's funding issues and challenges.
Well, honestly, we do anticipate the demand to come from both, because we really do think we were already serving many individuals who ultimately, like through the LIP program, we're finding we were seeing those adults, and they were uninsured, and now they have access to the LIP program. That's going to translate into Medicaid. So there's going to be that segment of our population that we need to retain, and then also attracting the new folks. So we really think it's going to be a balance between both. And if that balance works out well, it could ultimately be a benefit to us in the end, because if we are able to bring a reimbursement stream behind those individuals, I mean, it's amazing what we're able to do under the current circumstances, which is having lost all state funding for special populations. You know, $35 million wiped out with the blue pencil a couple years ago. Lost adult dental overnight. That's a $7 million cut to the health centers. ADHC, you know, obliterated. And so despite these significant cutbacks, because the infusion of federal dollars have really been about capital principally and creating new health centers, not necessarily ongoing operational dollars. So if anything, we've been taking very significant cuts, yet the numbers that we're serving continues to go up and up and up. So even in, I think, some really challenging circumstances, community health centers numbers in terms of who they're serving have pretty much doubled since 1997. So, you know, the growth in terms of so under those really challenged circumstances, we're somehow able to keep going forward. If things could potentially get better for us by receiving more paying clients, that could be very helpful. Now, we are facing other challenges in terms of our reimbursement, for example, with the governor's proposal, which was to eliminate our core funding mechanism, which is the PPS payment system for community health centers. That's our enhanced Medicaid payment. That is the core backbone of funding for community health centers, which is a significant better reimbursement than what we would have received under fee-for-service Medi-Cal, which actually those community clinics that aren't federally designated are receiving that burdened fee-for-service rate, but they struggle financially as a result. So part of that will be ensuring that the payment structure that we have in place, which is part of what allows us to have that balance between the uninsured and the insured, having a stable Medi-Cal funding stream has been really critical. It's been the financial backbone of the health centers. So we are going to be challenged as well with fighting back those kind of pushes and changes, but we're also recognizing that payment reform is one of the components of healthcare reform. And we are having to look at how that PPS payment system could evolve over time. And there's some protections in federal law that allow for some experimentation of the PPS system. For example, moving it from a per visit payment to a capitated equivalent. So where you're on some form of capitation, but it's really grounded in your PPS rate. And we are looking, which was very similar to the governor's proposal actually, and we are looking at how we could pilot test implementing some of those new models. So we recognize that our funding stream may not be guaranteed, you know, forever, and we do need to look at innovation, and potentially if we did move to some form of a capitated model that might allow for more flexibility to do things like work with promotoras and community health workers and other kind of providers, there are some benefits to getting out of the way we could have our hands tied under the current reimbursement system. But that needs to be transitioned in. It can't be a wholesale overnight, pull the rug out from under us and put us, you know, cut our funding and completely change it. So we are also exploring those options. It's both a challenge and opportunity that we face. What will be the future of the payment system for community health centers in California?
Great, thank you. So I think that was a great segue to talk a little bit more about policies, the state or local policies that you're either, you know, advocating for or hoping that to take place to sort of ease the way, particularly, you know, Ron, maybe we can start with you talking about the issues. You've sort of alluded already to some of the efforts for the undocumented population or the unauthorized immigrant population, but also in general, maybe you can talk a little bit more about that.
Yeah, I think we certainly are interested in looking at different coverage models that we may be able to bring to California to get to the problem of how do we cover all the people that have been left out of the ACA. So we're hoping to work with core partners that work on immigrant health and that care about the issue to develop those ways, maybe look at potential public-private partnerships, and also look at coverage options that may be available in certain employment sectors where we can create some type of purchasing pool to get undocumented workers covered. But we also like to make sure that we can really maintain access to the state programs that we have right now. Obviously, I mentioned a few state-funded programs earlier. We want to make sure that those state-funded programs continue. So we're going to be certainly keeping an eye on Election Day and what's going to happen with the tax initiative, and also making sure that in the budget cycle that there aren't mistaken assumptions by people in various departments in the state that they think it's okay to start saving money in certain areas for certain programs, given that we have broader coverage available for the general population, because that's something we certainly would not want to see. So certainly keeping eligibility and access open to those programs and increasing funding where we can, depending on the fiscal environment. We also think, and obviously some of you may know there was a bill that could have developed and implemented the basic health plan in California. We do think a basic health plan could be very useful for immigrants, especially lawfully present immigrants who right now are in full scope Medi-Cal, which is a state-funded program, but are also eligible for the exchange with subsidies. But we know if they're already income eligible for the state-funded program for Medi-Cal, it's going to be pretty expensive and unaffordable for them to get coverage in the exchange. So really making sure that we can maintain that program or have a robust basic health plan that has the wraparound benefits, just like Medi-Cal, that can provide coverage for this particular population. Also, there's a number of local programs that we also would like to make sure that we protect. Obviously, there's open access to care in San Francisco and in Los Angeles. And we also have a number of children's health initiatives around the state that provide coverage for undocumented children. These programs are hurting for funding, and we really want to make sure that there are funding mechanisms available to take care of this population. And as I mentioned before, and I'll say it again, it's not just undocumented immigrants that are going to need access to care and for it to be open. So I think those are the type of things that we'd like to see happen and stay in place as we move forward towards 2014.
Thank you very much. Carmela, would you like to address the same issue?
Well, I totally agree with what Ron just said, and certainly making sure that the Medicaid expansion happens in our state is going to be our key challenge after this election, and that's going to absolutely be a priority for all of us, and make sure it happens in the appropriate way. We have issues now in terms of being vigilant about the LIP transition, and what does it mean, because that is an opportunity to just shift all these folks over into Medi-Cal. Well, how is that really going to happen? So I think paying attention to that component of the LIP program will be a really important policy. But I think Ron really touched on all the things that we're going to be watching for as well.
Right. So I think people may know that there's a lot of effort is currently going on in terms of making sure that there's a smooth transition for the current enrolled LIP population. I mentioned a few minutes ago about 95% of the currently enrolled population are Medi-Cal eligible. So there's a lot of work going on around how do they actually transition that population without losing many of the people, including strategies of sort of thinking about how can the eligibility determination that's already the LIP eligibility determination is consistent with Medi-Cal eligibility, so it would be great if those people can not have to go through the same process over again, transfer. So there's a lot of those. Okay, so if anybody on the panel would like to say something more, otherwise we can go to the audience and take questions.